Electrocardiography or ECG is a fundamental tool used in nursing and healthcare to monitor the electrical activity of the heart. Understanding the ECG is critical for nurses working in both acute and chronic care settings. This video is designed to give you a simple and clear overview of ECG Basics so you can feel confident interpreting basic rhythms and identifying when urgent action is needed. Let us begin with the foundation. The heart has its own electrical conduction system which controls the rate and rhythm of the heartbeat. This system includes the sinoatrial node, atrioventricular node, bundle of his bundle branches and Purkinje fibers. The sinoatrial node, located in the right atrium, is the primary pacemaker of the heart. It initiates electrical impulses that travel through the atria, causing them to contract. Then the impulse reaches the atrioventricular node, which slightly delays the signal to allow the ventricles time to fill with blood. From there the signal travels down the bundle of his into the right and left bundle branches and finally through the Purkinje fibers, which cause the ventricles to contract. An ECG records these electrical signals in a graphical format. It is typically displayed across multiple leads, which are different views of the same heart activity. The standard ECG used in most healthcare settings is a 12-lead ECG. Each lead shows electrical activity from a different angle, providing a comprehensive picture of the heart's rhythm and function. For basic rhythm interpretation, nurses typically rely on lead 2 because it offers a clear view of atrial and ventricular activity. Now let's break down the components of an ECG waveform. A single heartbeat on an ECG consists of several distinct waves and intervals. The first wave is the P wave, which represents atrial depolarization or the contraction of the atria. The next component is the PR interval, which is the time the electrical impulse takes to travel from the atria to the ventricles. The QRS complex follows, and this represents ventricular depolarization or the contraction of the ventricles. The SD segment and the T wave reflect the process of ventricular repolarization or the heart preparing for the next beat. To interpret an ECG accurately, nurses need to understand rate, rhythm, and wave morphology. First, to calculate heart rate, you can use the rule of 300. This involves counting the number of large squares between two consecutive R waves and dividing 300 by that number. For example, if there are 4 large squares between R waves, the heart rate is 75 beats per minute. Next, look at the rhythm. A normal rhythm called sinus rhythm originates in the sinoatrial node and should have a P wave before every QRS complex with a consistent PR interval. Irregular rhythms can be caused by a number of conditions, including atrial fibrillation, heart blocks, or premature contractions. Recognizing these patterns can help nurses act quickly in emergencies. Another important concept is axis deviation. The heart's electrical axis is the general direction of electrical flow in the heart. A normal axis ranges from -30 to +90 degrees. Deviations from this range can indicate conditions such as left ventricular hypertrophy, right ventricular hypertrophy, or conduction abnormalities. Let's now examine some common rhythms nurses must be able to recognize. Atrial fibrillation is one of the most common arrhythmias. It shows an irregular rhythm without distinct P waves. The QRS complexes may appear normal, but they occur at unpredictable intervals. This condition increases the risk of stroke and often requires anticoagulation and rate control medications. Sinus bradycardia is defined as a heart rate under 60 beats per minute. It usually presents with a regular rhythm and visible P waves. It can be normal in athletes or during sleep, but it may also indicate a serious problem if the patient is symptomatic. Sinus tachycardia is a heart rate over 100 beats per minute. It maintains a regular rhythm with normal PQRS and T waves, but can be a sign of pain, dehydration, fever, anxiety, or other stresses. Supraventricular tachycardia is a very rapid heart rhythm that originates above the ventricles. It often presents with a narrow QRS complex and a rate above 150 beats per minute. It may require vagal maneuvers, medication, or cardioversion if the patient is unstable. Ventricular tachycardia is a potentially life-threatening rhythm. It is usually wide, complex, and regular, and may or may not have a pulse. If pulseless, it requires immediate defibrillation. If the patient is stable with a pulse, medication may be used. Ventricular fibrillation is a chaotic, disorganized electrical activity with no identifiable PQRS or T waves. It is a medical emergency and requires immediate CPR and defibrillation. Asystole, also known as flatline, is the absence of any electrical activity. This is a non-shockable rhythm and requires immediate CPR and investigation into reversible causes. Pulseless electrical activity shows organized electrical activity on the ECG, but there is no palpable pulse. This also requires CPR and identification of underlying causes such as hypoxia, acidosis or cardiac tamponade. Interpreting a 12-lead ECG is more advanced, but it's good to understand some basics. Each lead represents a different viewpoint of the heart. Leads I2 and 3 are limb leads, augmented leads AVR, AVR, and of give frontal plane views. Precordial leads V1 through V6 view the horizontal plane. Abnormalities in these leads can help identify myocardial infarction or ischemia. For example, ST elevation in leads 2-3 and of suggests inferior wall myocardial infarction, while elevation in leads V1 through V4 indicates anterior wall involvement. Nurses must also be familiar with signs of myocardial ischemia and infarction on ECG. Ischemia is usually indicated by ST depression and/or T-wave inversion, while infarction shows ST elevation in the affected leads. Another sign of a past myocardial infarction is the presence of a pathological Q wave. QT interval monitoring is also important, especially in patients on medications that prolong QT intervals. A prolonged QT can predispose the patient to torsade de pointe, a potentially fatal arrhythmia. Always check the corrected QT interval or QTC, which adjusts for heart rate. A QTC over 450 milliseconds in men or 470 milliseconds in women is considered prolonged. Artifact on ECGs can mimic serious conditions and confuse interpretation. Always ensure electrodes are properly placed, the skin is clean, and the patient is not moving during the ECG recording. Let's talk about electrode placement. Proper placement is critical for accurate readings. Misplaced leads can mimic or mask true abnormalities. For limb leads, place electrodes on the right and left arms and legs. For precordial leads, position them as follows: V1 at the fourth intercostal space to the right of the sternum, V2 to the left of the sternum, V3 between V2 and V4, V4 at the fifth intercostal space at the midclavicular line, V5 at the same level as V4 at the anterior axillary line, and V6 at the mid-axillary line. Nurses also need to understand how to respond to critical ECG findings. If you notice new ST elevation, notify the doctor immediately. If you see ventricular tachycardia or fibrillation, call code blue. Start CPR and prepare the defibrillator. Documentation is key. Always document the time ECG was taken, the reason for ECG, and any interventions provided. Finally, education and regular practice are essential for maintaining ECG interpretation skills. Nurses should take part in regular training courses, simulations and clinical reviews. Reviewing ECGs with senior staff can also improve confidence and accuracy. In summary, understanding ECG basics is an essential skill for nurses. It begins with knowing the electrical conduction system of the heart, recognizing the components of an ECG waveform, interpreting basic rhythms, identifying life-threatening conditions, and knowing when to escalate care. By building confidence in ECG interpretation, nurses play a crucial role in early detection of cardiac events and improving patient outcomes.